Hello, this is Dr. Edward Halperin. Welcome to 90 Minutes, the medical magazine of the web. This is webinar number 34, and we are convened today to talk about topics about best standard of practice in healthcare. We have a very interesting program for you today with the first two talks, the result of listener feedback. We had one of our frequent listeners specifically asked for two of our talks, and we have fulfilled her request by inviting speakers to address the questions she wanted to have addressed. And to that, we have added in several additional speakers addressing common issues in medicine and what is really the best standard of practice. Now, I usually say when we start these webinars that I'm your host, Dr. Edward Halperin, the Chancellor and CEO of New York Medical College and the Provost for Biomedical Affairs of Turing University, and that we're going to have some old friends and some new friends as our speakers. But it's different today. It's all new friends. We're going to have a group of speakers today who have not ever been on our webinars before. It might be called today's webinar as New Faces of 2026. Our topics this morning are going to start with what's the best standard of practice for the contact lens wearer. We have Dr. Amin from Westchester Medical Center, Department of Ophthalmology, and the faculty of New York Medical College. Our listener was concerned about articles she had read about the risk of amoeba infections associated with contact lenses after people went swimming or took a shower, and that provided the impetus for the topic. Our next speaker will be Ms. Gila Friedman. She is a geneticist at the Metropolitan Hospital Medical Center on the Upper East Side of Manhattan, and she's going to be addressing being tested for genetic proclivity to breast cancer. There are some new tests on the market with an expanded panel of genetic testing. We're going to discuss what's the right kind of genetic test to order for breast cancer and what should the patient do about proposals. Well, you've already had a test a few years ago, but now we have a bigger panel to test. We're going to talk about that. Next, there's been a lot written and discussed about whether for smokers they should undergo regular CT scanning to screen for lung cancer and see if they can identify early stage resectable lung cancer. Dr. Anna Rosenstein of Westchester Medical Center's Department of Radiology and the Department of Radiology of the School of Medicine of New York Medical College is going to be with us to discuss that. I've chosen as our next topic a very common problem for parents and pediatricians, primary care doctors, ER doctors. My child's bumped their head. Do I need to take him to the doctor? If I take him to the doctor, what should the doctor do about it? Letting children be children. Sometimes they fall off the playground equipment, they bump their heads, or if you're having the child play in a soccer league and they head the ball, or playing school football, these are real risks. Our guests are going to be Dr. Stephen Wolf, who's the chief of pediatric neurology at the Maria Ferrari Children's Hospital of WMC Health and on the faculty of New York Medical College. He's going to be accompanied by Patricia McGoldrick, a nurse practitioner in pediatric neurology, to talk to us about that topic. We're going to conclude our presentations with a talk related to the article that was recently in the papers that you may have seen on television news about the recall of baby formula. What's a mother to do if a decision has been made to bottle feed either instead of breastfeeding or in addition to breastfeeding? What do we need to know about standard of care of commercially available baby formula? What is someone to do if the baby formula gets recalled? Our speaker will be Dr. Jennifer Caswick. She's a neonatologist at the Maria Ferrari Children's Hospital and an assistant professor of pediatrics at New York Medical College. She's going to chat with us about that. As always, if you have questions for any of our panelists, please type them in the question box on your computer screen. I will get to as many of them as possible during the question and answer part of our program. For those of you who are interested in continuing medical education credit, I will appear intermittently during the intervals between the presentations and explain to you how to get your CME credit. As always, welcome back to 90 Minutes, and let's get started with our program.
Hello, I'm Dr. Abba Amin, and I am Associate Professor of Ophthalmology at New York Medical College. I'm also Chief of Complex Anterior Segment Surgery at Westchester Medical Center, and I'm here today to talk about contact lens safety and preventing vision loss. I have no relevant financial disclosures. So, 45 million Americans wear contact lenses in the United States. That gives you the sense of scope of how big a topic this could be. 1 million Americans seek health care annually for contact lens related complications. It is a FDA medically regulated device, and it has inherent risks when used improperly. 99% of wearers report at least one poor hygiene practice, and 1/3 never receive proper lens care instructions. So here they are. Many benefits for contact lenses. Excellent optical quality, wider field of vision, and cosmetic advantage over glasses. They are safe and effective when used properly. So we do have risks. Microbial keratitis or corneal infection. This can cause permanent vision loss, and corneal ulcers or infections can cause perforation of the cornea, leading to loss of the eye in severe cases. Here's a picture of a bacterial corneal ulcer. The most common organism that causes this is Pseudomonas. And what it's done here is it's embedded itself in the cornea, this white central spot, and there's a layer below called a hypopion, which is layered infection white blood cells. So here's a sense of the numbers. 2 to 4 cases per 10,000 contact lens wearers annually get a corneal ulcer. This can cause permanent vision loss depending on the location of the ulcer, and 0.6 per 10,000 wearers a year get this, to the cost of $175 million a year. 90% of the infections are bacterial, 40% are Pseudomonas, the rest are Staph aureus and Streptococcus. 10% are caused by fungus or acanthamoeba. Here we have 4 images. A shows a bacterial corneal ulcer, which is involving the central visual axis. This will permanently affect this patient's vision even when it's healed. B as well, it's affecting the center. C shows a picture of an acanthamoeba infection, which has a ring infiltrate, very different. And D has a viral ulcer. Extended wear versus daily wear makes a difference in terms of your risk. Extended wear carries 21 per 10,000 wearers per year having a risk of a corneal infection. They wear it many more hours a day. Daily wear also involves repeated use of the lens over time, so carries the next amount of risk. And the least risk is with daily disposable lenses because every day you put them in and throw them out. Reduces the wear time per lens. The key risk behaviors are wearing the lenses longer than you're supposed to, and of course, sleeping in your contact lenses. That's a big no. Acanthamoeba keratitis can be a very devastating infection. The epidemiology shows 2 per million in the general population. However, that risk rises to 27 per million in contact lens wearers. 1 in 21,000 soft contact lens wearers will have this infection. Over 90% of the cases involve contact with water. There's a 39% treatment failure rate with acanthamoeba infection. That's serious. Here's a picture of a confocal microscope image of acanthamoeba infection. These microscopes are difficult to come by. They are run with a laser, and they show the white spots here are the acanthamoeba cysts in the cornea. Water exposure is the critical risk factor. Acanthamoeba lives in water, in tap water, in your house, well water, distilled water, pools and hot tubs, even the ocean. 71% of cases have documented water exposure. So the specific risks are showering in lenses, swimming in lenses, rinsing lenses in tap water, and never store lenses in tap water. So you should remove your contact lenses before you shower. Why? Because acanthamoeba lives in the water. It lives in all water sources. Water exposure is the #1 modifiable risk factor for acanthamoeba keratitis. 86% of the soft lens wearers will shower despite the risk, or maybe they don't know about the risk. So the evidence is pretty clear. If you get water into your eye, you're taking on the risk of an acanthamoeba infection. Swimming in pools and hot tubs is also very dangerous. 60% of contact lens wearers will do it anyway. So you are increasing your risk 6-fold of getting this devastating infection if you do so. So if you must use contacts, wear goggles. And if you do get water exposure, remove the lenses immediately. Do not reuse those lenses. So evidence-based safety recommendations: good hand hygiene, wash with soap and water, and dry them before you touch the lens. Avoid water getting into your eyes when you wear a contact lens. And good lens care with proper solution. Remove the solution every day, clean your case, and change your case every 3 months. So follow the prescribed schedule for the contact lenses, be them extended wear, throw them away when you're supposed to, and weekly and daily lenses should be used as prescribed. When to seek care: when you have redness, pain, swelling, or any sign of infection, remove the lenses and see your healthcare provider or ophthalmologist. Common misconceptions: what they don't know can hurt them. 50% sleep in their lenses when they were told not to. And only 20% know that they're supposed to remove and clean their case every night and put new solution in. 1/3 of the patients say they never received proper care instructions, so here they are. And many people believe distilled water is safe. It is not. And colored contact lenses are a risk that you're taking just because they want to look nice, and you're taking an increased risk because these can be contaminated with microbes. They are not as thoroughly vetted. Education, education, education. So back to the acanthamoeba keratitis, why prevention matters: because this is a difficult infection to treat. It takes oftentimes 30 days to make the diagnosis in the ophthalmologist's office. Most of the time it gets misdiagnosed and it gets referred, and so there's a delay in the start of treatment. And many of these patients, up to 30%, will require a cornea transplant to be treated. And 39% have treatment failure, so it's very serious if you're the one who gets the infection. Most likely you will not recover the vision that you had before. And it is actually a very painful, prolonged treatment that can take many months, up to a year. Alternatives: glasses, always the safest option, and refractive surgery for those who cannot be without freedom of glasses. So that's a whole other topic in and of itself. So key takeaways to prevent vision loss: never expose your lenses to water. Daily disposables are the safest. You must throw them out every day. Wash your hands before you touch the water, but make sure you dry them because that will be water right there on your hands. Use FDA-approved solutions. Replace the lens case every 3 months because it can harbor bacteria. Seek immediate care for redness, pain, vision loss, or discharge of the eyelids, and an annual eye exam to make sure you're using your contact lenses properly and not having other consequences. So most complications are preventable through proper care and education. Here's a list of my references for anyone who wants to dig a little deeper into my content. Thank you so much for listening.
Hi, everyone. Thank you so much for having me. My name is Gila. I'm a genetic counselor at Metropolitan Hospital, and today I'm going to be discussing genetic testing for breast cancer. I first would like to say I'm an employee of PAGNI. I work with patients at Metropolitan Hospital, and I have no conflicts of interest to disclose. So genetic testing for breast cancer has certainly come a long way in the last number of years. Originally, it started out many years ago by just testing for BRCA1 and 2, and now we have turned into doing panels, which include a number of genes. There are 2 different types of panels that we do for genetic testing for people with breast cancer or people with a family history of breast cancer. The breast cancer GYN panel is an organ-specific panel, and what that means is that we just test for genes related to breast and gynecologic cancers, including ovarian cancer and uterine cancer. So these panels can include genes associated with hereditary breast and ovarian cancer syndrome, like BRCA1 and 2, as well as genes that increase the risk for breast cancer, like PALB2, CDH1, and CHEK2. We also include on these panels genes for Lynch syndrome. The reason for this is that although Lynch syndrome is primarily associated with colorectal cancer, is that a lot of these genes also carry risk for uterine cancer, as well as maybe an increased risk for breast cancer. Generally, these organ-specific panels include 20 to 30 genes. Now, a comprehensive genetic testing panel includes genes that test for many other systems, such as gynecologic cancers, gastrointestinal cancers, endocrine cancers, GU, skin, and brain cancers. Generally, these panels are a lot larger and can include 50 to 90 genes. Now, there are many reasons why patients may choose to go with a larger panel or a smaller panel. Some patients may want a larger panel because they're curious. So when we counsel them and we offer them these options, they say, you know what, I really just want to know everything as much as possible. And that may be why somebody goes with a non-organ specific panel. They also may have a personal or family history of multiple different cancers. And that could be, for example, they have a personal history of breast cancer, but maybe a family history of skin cancer or GI cancer. And that may be why they choose to go with a larger panel. Some patients may want fewer genes on their panel because they want less uncertainty with results. So there are 3 types of genetic testing results we get from these panels. The first is a positive, meaning we found a genetic change that explains why somebody has or a personal or a family history of cancer. We can get a negative, meaning we didn't find any genetic changes. And then we can get an inconclusive result. That means we found a variant or a genetic change, and we're not sure if it's associated with cancer or not. Now, those inconclusive results come at a much higher frequency with the larger panels, and that is why a patient may choose to go with a smaller panel because they want less of those results. They also may choose to just focus on what's in the personal and family history. Maybe they don't want all of the information in the world. A lot of genetic testing these days, especially when it comes to cancer, is including RNA testing. Now, RNA testing is in addition to the DNA testing, and it's similar to a functional study. RNA testing shows how genetic variants can affect splicing and can tell us whether the genetic change, the DNA change, reveals an abnormal transcript and can actually affect the function of the protein. And this is really helpful because it can minimize the number of those inconclusive results that I was just talking about. This is becoming more commonplace for a lot of genetic tests with cancer, and now it's actually moving into other spaces such as the prenatal space as well as the pediatric and neurologic space. I think there are many ways that the future of genetic testing is going to go. I know that there is a lot of questions out there about DNA banking and whether DNA samples are going to be retained to do additional genetic testing as our technology becomes more advanced. And this really isn't done for cancer genetic testing. It may be done for others, but cancer is not really the space that this is done for. One of the main reasons for this is that each state has different rules about sample retention, and New York State's rule is 60 days without explicit consent from the patient. So when I'm consenting for genetic testing, I will offer the patient if they want their sample retained for longer than 60 days. I'll say most often those patients choose not to have their samples retained. And the better option is usually we say to repeat the genetic testing after about 5 to 10 years with the advance of genetic testing and with better panels that are coming out or maybe more advanced RNA testing. Another place where I feel like the future of cancer genetic testing may be going is in the direction of whole exome sequencing. This is a more advanced genetic technology that came out maybe 2 decades ago. It's not really used in the cancer space. It's primarily used in the pediatric and neurologic spaces. And this can look at all of the exons and sequence all the exons in the genes related to somebody's phenotype or clinical features. And whole exome sequencing is very good at using the technology to identify new genes and new variants that could be related to hereditary cancer syndromes. And like I said, I think that also expanding RNA testing will improve the genetic testing utility by lowering those inconclusive results and determining which variants have a serious impact on the transcript of the gene. I want to thank you so much for your time, and I would be happy to take any questions.
Hello again, this is your host, Dr. Edward Halperin, here to tell you how to get your continuing medical education credit for those of you seeking CME credit. Today's program is approved for CME credit by the Office of Continuing Medical Education of New York Medical College. You have two basic choices. You can get out your cell phone and send a text message to 828-295-1144. That's 828-295-1144. In that text message, send the code 62OHED, all in capitals, 62OHED. You're going to tap the phone, and for sending the text message, you're going to get a text message back, which will take you to the link to fill out your audience satisfaction questionnaire and to get your CME credit and get your certificate sent electronically. Now, the other choice is to take your handheld device and scan that QR code in the left-hand corner of my screen. And if you do that, you're going to get taken to the link to the website and once again fill out your satisfaction questionnaire and get your CME credit certificate. Either way works, but both will only work until Monday, March 2nd at noon. After that, the system will shut down. I suggest you either take a screenshot, write this down, record the information you need for your CME credit, and go right ahead and do it so that you won't have the deadline passed and be disappointed. So that's how you're going to get your credit. And as always, if you have questions for our panelists as today's program proceeds, please type them in the Q&A box on your screen, and we will try to get to as many of them as possible during the Q&A part of our program. Once again, thanks for joining us, and let's get back to our presentations.
Hello, good afternoon. I'm Anna Rosenstein. I am a chest radiologist at Westchester Medical Center, and today I'm going to tell you about best practices for lung cancer screening with CT. I have no conflicts of interest. Okay, the most effective way to prevent lung cancer death is smoking cessation. Having said that, we're here to talk about lung cancer screening. And so lung cancer screening becomes important approximately 75 years ago, when in the 1940s it becomes the second most frequent cause of cancer death. And in the 1950s, smoking peaks, and the American Cancer Society links smoking and lung cancer. By 1964, U.S. Surgeon General report says that smoking cigarettes causes lung and laryngeal cancer. Now, what's the rationale for screening? If lung cancer is found during a search, because the patient is presenting with symptoms, over 75%, 3/4 of these patients are going to be incurable at presentation. And the survival rate at 5 years is abysmal. It is less than 5%. Here you are seeing a slide, and that's an image from a lung CT. What you see here is normal right lung, the bronchi, and here this big mass in the left upper lobe surrounding the aorta and basically spreading through the lung. This is the usual presentation, a large mass which is incurable and cannot be resected. Now, if we find a lung cancer when very early in what we call 1A stage, very early on, the survival rate is over 70%. Here you're seeing a tiny little nodule in this yellow circle. Now, we don't know if it's a benign nodule, malignant nodule. So what are we going to do? We're going to repeat the scan in 6 to 9 months. And in fact, we have repeated the scan. This is the nodule. It is bigger, right? We take it out. Now the survival is over 70%. Okay? Now, so we really want to find them early. And the beginning of screening, the idea starts in the 1980s when randomized controlled trials of chest radiography, chest x-rays begin in the United States, in 3 sites, and in Czechoslovakia. Now, while randomized control, you're going to hear these words. The only way to tell us that lung cancer screening is effective is to show that in a randomized controlled trial, when you have 2 populations, okay, you take a group of patients, divide them in half randomly, and then screen one part and don't screen the other. This is called randomized control. It removes all biases and shows us that people will die less from lung cancer in the screening group. These are the only trials that can be used to demonstrate screening effectiveness. So they're conducted in the 80s with chest x-rays and not found effective. Why? This is a chest x-ray and a lung nodule. Everybody can see the lung nodule. CAT scan shows it. This is another patient. This x-ray really doesn't show the lung nodule. It's there. It's there at CT. There it is. But if you go back, you'll notice it's hiding behind the rib. So overlapping structures, that's a big problem. So x-rays are not effective for screening lung cancer. And in the 1990s, CT becomes available, helical CT. And here you're seeing the first trials of CT in lung cancer screening in Japan. They loaded a scanner on a big truck and drove it from one city to another. It was not randomized controlled, but it showed that lung cancer can be found early. But it also showed that there are lots of little benign nodules that are quite confusing. Here you see all these benign nodules happen to be infection. Okay, 40% of these patients will have a nodule, and they worry until we follow and determine that the nodule either disappears or is stable. So lung cancer screening is not without its detriment and anxiety and cost. By the first decade of the century, low-dose CT becomes available. Now, you see the low-dose CT in front of you. This is the coronal reconstruction. This is just lung windows, beautiful quality. You see absolutely everything, low-dose CT. Very decent quality of the soft tissues with, you see the calcification in the coronary artery. You see some detail in the bones. And the dose is approximately 1.5 millisieverts. Doesn't tell you anything, but tells me it's about 10 x-rays approximately, maybe a little less, maybe a little more, but it's about 4 to 5 times less than a regular chest CT at that time. And so randomized controlled trials take place. In the next 10 years, approximately 10 randomized controlled trials are held throughout the world, and they show 17 to 33% mortality reduction from lung cancer. Now, that's important. The largest study, NLST, is conducted in the United States, and that is 54,000 people, right? So it's a very convincing trial. And U.S. Preventive Services Task Force in 2013, I believe, recommends screening smokers 55 to 79 years of age And the next recommendation in 2021 is to screen smokers 50 to 79 years of age to include more high-risk women and racial minorities who get lung cancer more frequently and at an early age. And the American College of Chest Physicians, American Thoracic Society state that lung cancer screening with LDCT can result in more benefit than harm if it is performed in a high-quality screening program. And here we're going to come to what constitutes high quality. Lots and lots of attributes, but the most important is that we stick to eligibility criteria, educate our patients, and conduct image review and refer to a large and well-developed treatment network. Eligibility, as we have already said, adults 50 to 79 years of age. CMS funds it to 77 years of age, by the way. CMS is Center for Medicare and Medicaid. Now, smoking history should be at least 20-pack year smoking history, either continuous now or quit within the past 15 years. And screening should be discontinued if the person has not smoked for 15 years or develops a health problem that limits their life expectancy or ability or willingness to have curative surgery. Education. We need to talk to our patients and present to them their risks. Let's take a 58-year-old woman who has 30 years smoking history and has a risk of lung cancer of 0.7%. That's a very low risk, right? Now, her benefit is 1 in 1,000, and she's got significant risks of, for example, additional studies, worrying. Remember, 40% of these patients are going to have a nodule, just probably benign, okay? Or let's take another patient, 72-year-old male with a very long smoking history, whose the risk of lung cancer is approximately 10%, which is very high, and he's got the benefit is 19,000 and significant, 19 fewer deaths in that 1,000, right? So at this point, that man's risk is significantly greater than the potential risks of lung cancer screening. The benefits are great. So obviously, right, we need to talk to our patients and educate them. And this is called joint decision. It is our responsibility of screeners to have online presence and answer questions in the vein of communication and patient education. Ordering has to be done by a physician or qualified non-physician. Image acquisition should be on modern scanners able to deliver low dose and have high diagnostic quality. Physicians who interpret the studies have to be board certified and need to have significant experience interpreting at least 300 chest CTs in the preceding 3 years. Image review has to be performed properly with comparison to the baseline so you can see slow increase in these little nodules over the course of the years, and also to have availability for 3D reconstructions with volumetrics, which show you growth earlier than just eyeballing on multiple studies. Now, having said all that, what's our state of the union? Lung cancer screening is successful and the rates are increasing. But in 2010, the very beginning, we screened approximately 4% of eligible population. By 2020, we were doing 16%, and in 2022, it's approximately 22%. I believe it's almost a quarter of the eligible population is being screened right now. We produce our reports in a structured format to avoid confusion. The patients are codified by categories with modifiers. For example, let's talk about them. This is a clearly benign hamartoma. This is leave me alone lesion, and it needs to be clearly stated. This is a lung cancer with very, very high risk of being lung cancer. Why? It's a speculated mass, and it has pleural plaques, okay, which show you that the patient had asbestos exposure, which make this almost by definition a lung cancer. And this is an incidental finding. This is a pseudoaneurysm of the aorta that needs to be treated. And all of these statements must be made with clarity using the appropriate and accepted standards of reporting, these modifiers, to prevent confusion. We need to have a well-developed clinicians network, clinicians who are able and are trained in management of lung nodules, and surgical and medical treatment for lung cancer when it is found. We need to have smoking cessation support in the institution, right, which increases cost effectiveness of screening by 20 to 45%. It's enormously important, right? So the take-home points of all this: lung cancer screening with low-dose CT saves lives. It does carry risks, and therefore, okay, it can do more good than harm only when it is performed in high-quality screening programs. Screening rates in the United States are rising, and adherence is improving. But we still do not do enough LDCT screening, particularly in the vulnerable population. This battle is winnable. Thank you for your attention.
Hello again, this is your host, Dr. Edward Halperin, asking you to consider giving back to New York Medical College. The programming that you are viewing today provides free CME credit, but obviously putting on these programs don't come for free. There is the time and effort of our speakers and the considerable time and effort of the IT team to put on these webinars. We hope some of you will consider financially supporting the webinars that you're watching and the research projects at New York Medical College that underpin the opinions that you're hearing. You can help by making a tax-deductible gift to help offset our costs. Great things are happening here at New York Medical College, and we hope you'll be part of it. If you want to make a donation by phone, if you phone 914-594-2720, a pleasant person from the fundraising office will be happy to take your phone call and take your credit card information over the phone. If you're an online person, donations may be made online at the website www.nymc.edu/give. And for those of you who like to get out a checkbook and write a check with ink, you can do that, put it in an envelope and mail it to New York Medical College Office of Development, 40 Sunshine Cottage Road, Valhalla, New York, 10595. Please put on the memo line of the check, webinars. Thanks for thinking of us. We hope everyone stays safe and healthy. And as always, if you have questions for any of our panelists, please type them in the Q&A box on the screen, and we'll get to as many of them as possible at the end of our program when we get to the Q&A section of today's broadcast. Let's continue with our program.
Hello, everyone. I'm Stephen Wolf, the Chief of Pediatric Neurology at Boston Children's and Maria Farrar Children's Hospital, and a Professor of Neurology and Pediatrics at New York Medical College.
And I'm his partner, Patty McGoldrick, a nurse practitioner in child neurology at the same places. And we specialize in epilepsy and headaches and all other things neurological.
Thank you for joining us. These are our disclosures, which are not relevant to the talk, that have mainly to do with drug studies that we are involved with. So we want to talk to you about minor injuries in children and what to look for and what to worry about. And the most important thing is we all get scared of when a child falls and hits their head. And it's important to examine a child and to see if there's anything that seems significant or worrisome. So the things that we tell families to look for is looking for bruising behind the ear, which would suggest a skull fracture, bruising in both of the eyes, big raccoon eyes, that would also suggest either significant trauma to the head or even some blood behind the eardrum.
So, what are the most common causes of minor head injuries? And everybody really does worry about their children falling and hurting themselves. The most common things are falls, children falling off of beds, changing tables, falling down the stairs, falling on the playground, off the top of the slide, off of a swing are pretty common. So, what you want to ask yourself is, was this an accidental trip? Did the child just trip over something and fall, or was there more to it? Like, did the child first faint and then fall? Because then you would worry about a syncopal or a fainting episode or a seizure that you hadn't seen before. So we usually ask, in the case of seizures, have they had a history of staring spells or do they have a history of seizures? Or were they hit by something? Did somebody else on the playground hit them? Did they bump their head? So the symptoms typically of minor head injuries is they immediately cry. They have a headache that doesn't last for very long. They can have a small bump or bruise on his or her head, and sometimes they're irritable for a little while afterwards. Swelling happens later, so swelling doesn't usually happen right away when they bump their head. The biggest thing that happens is they bleed. So scalp wounds bleed a lot. You think your child is dying and is going to exsanguinate and bleed to death, but it's not a sign of an extreme injury. It just means that it was in a place where there was a scalp wound. If the bruise is small and the bleeding stops quickly, that's a good sign. And again, swelling happens later in the course.
And those pictures that we showed you are the things that we want you to look for. And I really should have put those pictures just now. But what's the immediate first aid? Most important is to stay calm. Applying cold compresses, an ice pack, or some frozen peas wrapped in a towel would really help. And put that on for a few minutes, especially to reduce the swelling. And encourage them to rest, hang out, watch a little TV, and you guys keep a close eye on them. But again, clean any of the minor cuts with soap and water, and hold on to the bleeding area with compression with a towel or paper towel to help to stop and allow the clotting to happen.
And again, most important to really stay calm because when we're upset, the kids get upset. So the danger signs. So as Steve said at the beginning, the battle sign, the raccoon eyes, those are the things to worry about and to look for a medical professional. The other things that would cause you to seek immediate emergency care is if the child is not back to himself, if the speech is slurred, they're confused, they have unusual behavior, if there was a loss of consciousness, if after that you can't wake them up, if they're really drowsy or not responding to you. Repeated vomiting. So not one vomit, but 2 or 3 times that they keep vomiting. Also looking at their eyes, seeing if their pupils are of unequal size, one bigger or smaller, one bigger, one smaller. If they can't walk, if they're weak or they're numb, they can't feel things, loss of sensation, any kind of seizure activity. Sometimes kids will fall and they'll have sort of one jerk and people will think it's a seizure, but it's important to have that evaluated. Also, if they have any clear fluid or blood coming out of the nose or the ears, it is worth definitely going to the emergency room and finding out what's going on.
So we recommend monitoring them at home if none of these emergency warning signs are there, and just really keep a good eye on your child. It's fine to let them sleep. You can check on them periodically. Using acetaminophen or ibuprofen for pain is perfectly fine, but excessive amounts of ibuprofen is probably not recommended because of the risk of it affecting the platelets and allowing bleeding. But 1 dose or 2 doses should be perfectly fine in a child who's not on it chronically.
All right, and then the return to normal activity. This is a question that always comes up about when you can allow them to go back to what they would normally be doing. So we usually advocate for a gradual return to play or sports, taking it a little bit easy for the first day or two. We ask them to rest both physically and mentally so that there's less screen time. They're on the screen all the time, so it's hard to limit that. We usually say they can listen to music, they can stay home and bake cookies with their parents, they can be read to, that sort of thing, so that they're not staring at a screen all the time. And then if they start having symptoms during this gradual return to activity, we slow it down. So we keep them out for another couple of days, let them to go back to school in a gradual fashion, half a day at a time and then a full day.
And this is what we tell people that if it's clearly a concussion and nothing more severe, if it's very minor bump with just a little bit of bleeding, they can return back to activities even faster. So this is just sort of a general terms.
Prevention. So how do you prevent these falls and things that happen to kids? So you can always wrap them in bubble wrap and send them out like that, but that's probably they're not going to make friends like that. So we recommend always using safety gates on stairs, always using car seats and boosters, not letting them loose in the back seat with the adult seat belts on them. And then ensure that they wear helmets. Kids do not wear helmets to ride bikes and scooters. And really, there's a law about children under 14 wearing helmets. It's good to enforce that. We say to the kids, when you're riding your bike, you need to wear a helmet. When you're scooting, so definitely on a skateboard and when skiing. And we just make that, that's what everybody does. You're going to wear a helmet.
So when to call the doctor if it wasn't one of those early emergency questions, and that's if the headache persists or gets worsens. If the child doesn't seem right, they're a little confused, goofy, wobbly, the symptoms are lasting longer than a week. There's other things to look for. What we already mentioned is the constant headache and the dizziness that won't go away. And of course, really a change in behavior, more irritability, something that just doesn't look right. So we always tell families, trust your instinct. If it just doesn't seem normal, then come and get reevaluated.
All right, when to go to the emergency. So this is after the initial evaluation. So we already talked about when to go to the ER when they first have the accident. So again, as time goes on, again, the unequal size of the pupils, again, if you're having trouble waking them up or they're excessively sleepy, if they complain of double vision or blurred vision, or if they're really pale looking and it lasts for more than an hour, again, seizures, any type of seizures, that's a delayed response. Ringing in the ears persistently. The child loses consciousness after some period of time. If they can't recognize familiar people, their parents, their siblings, they can't walk. Any child who can't walk needs to go to the emergency room. Also, if their arms are weak, you should have them evaluated. Confusion, difficulty concentrating, just not getting stuff done, slurred speech, stumbling or difficulty walking, or again, oozing blood or watery fluid from the nose or ears. So this can happen later, as well as right away in the beginning. So this is during the 24 to 48 hours that you're watching them a little bit more closely.
But this is just the good news is most children don't experience this. A small bump is not a serious, usually problematic thing. And if they don't meet this criteria, just treat them like a normal boo-boo, give them a kiss, and they should be fine. But these are the things we want you to look out for. And I hope that was really useful. Thank you for letting us come and visit.
Yes, thank you.
Hello again, this is your host, Dr. Edward Halperin, here to tell you how to get your continuing medical education credit for those of you seeking CME credit. Today's program is approved for CME credit by the Office of Continuing Medical Education of New York Medical College. You have two basic choices. You can get out your cell phone and send a text message to 828-295-1144. That's 828-295-1144. In that text message, send the code 62OHED, all in capitals, 62OHED. You're going to tap the phone, and for sending the text message, you're going to get a text message back, which will take you to the link to fill out your audience satisfaction questionnaire and to get your CME credit and get your certificate sent electronically. Now, the other choice is to take your handheld device and scan that QR code in the left-hand corner of my screen. And if you do that, you're going to get taken to the link to the website, And once again, fill out your satisfaction questionnaire and get your CME credit certificate. Either way works, but both will only work until Monday, March 2nd at noon. After that, the system will shut down. I suggest you either take a screenshot, write this down, record the information you need for your CME credit, and go right ahead and do it so that you won't have the deadline passed and be disappointed. So that's how you're going to get your credit. And as always, if you have questions for our panelists as today's program proceeds, please type them in the Q&A box on your screen, and we will try to get to as many of them as possible during the Q&A part of our program. Once again, thanks for joining us, and let's get back to our presentations.
Good afternoon, everyone. My name is Jennifer Caswick, and I am a practicing neonatologist here at Maria Ferrari Children's Hospital at Westchester Medical Center, as well as a board-certified lactation consultant and the medical director of the Liquid Gold Preterm Donor Milk Bank here at Westchester Medical Center. I'm excited for the opportunity today to discuss the topic of infant feedings. Infant feeding decisions can be complex and deeply personal. Today, we'll focus on situations in which a decision has been made to feed with formula rather than breast milk, and review what we should understand about the current standard of care for the use of commercially available infant formulas. I have no disclosures or conflict of interest. The objectives of my discussion today are to define the standard of care for infant formula use, describe regulatory oversight in the U.S., understand macronutrient and micronutrient adequacy, identify safe preparation practices, and recognize practices outside accepted medical standards. To begin, I want to clarify the terminology. When we talk about the standard of care, we mean the approach that is guided by clinical evidence, safety data, and recommendations from national professional organizations. The American Academy of Pediatrics, World Health Organization, and Centers for Disease Control and Prevention recommend an exclusive breast milk diet for at least the first 6 months of life, followed by continued breastfeeding with complementary foods for at least 2 years and beyond as mutually desired. While human milk remains the biologic gold standard, many families rely partially or fully on commercially available infant formula. And commercially available infant formula provides a safe and nutritionally complete alternative when breastfeeding is not feasible, medically contraindicated, or when families choose formula feeding. When we discuss commercially available infant formula in the United States, it's important to understand that these products are regulated by the U.S. Food and Drug Administration under the Infant Formula Act. This law establishes mandatory minimum nutrient requirements that all infant formulas must meet. These requirements are designed to ensure that formula provides complete nutrition for healthy term infants and undergoes pre-market growth testing. In addition, companies must comply with strict manufacturing standards, including quality control procedures and microbial safety testing. Facilities are inspected, adverse events must be reported, and the FDA has authority to mandate recalls when necessary. Overall, infant formula is one of the most tightly regulated food products in the United States, and as just discussed, is required to meet federally mandated benchmarks for safety, nutrition, and manufacturing quality. Commercially available infant formulas are designed to approximate the nutritional composition and functional properties of human milk. However, they do not replicate its full biologic complexity, particularly its bioactive and immunologic components. However, importantly, FDA-regulated commercially available infant formulas are nutritionally complete and meet established requirements for macro and micronutrient adequacy to support normal infant growth. Standard commercial infant formulas are designed to provide a standard energy density of about 20 kilocalories per ounce with the correct balance of protein for lean mass, fats to meet essential fatty acid requirements, and lactose as the primary carbohydrate to support normal growth and prevent nutrient deficiencies in healthy term infants. Beyond caloric density and macronutrient composition, infant formulas are required to contain specified micronutrients at federally mandated levels. For example, iron is included to reduce the risk of iron deficiency anemia, vitamin D to support bone mineralization and prevent rickets, iodine to support thyroid function and neurodevelopment, and zinc to promote normal growth and immune function. These micronutrients are essential during infancy, a period characterized by rapid growth and high metabolic demand, and their inclusion helps prevent deficiency states during this important period. Longitudinal clinical data demonstrates that infants fed standard iron-fortified formula achieve appropriate growth in weight, length, and head circumference. Although differences in body composition relative to breastfed infants have been described, these findings do not reflect nutrient insufficiency. Routine pediatric monitoring throughout infancy provides continued assurance of growth adequacy and safety. When selecting an infant formula, standard iron-fortified cow's milk-based formulas are generally considered first line for healthy-term infants. These products are nutritionally complete and supported by decades of clinical evidence. Alternative formulas, such as soy-based or extensively hydrolyzed formulas, should be reserved for specific medical indications. For example, galactosemia, confirmed cow's milk protein allergy, certain metabolic disorders, or significant gastrointestinal injury. Switching formulas without a clear medical indication, particularly based on marketing claims, is not evidence-based. Clinicians and families can be reassured that first-line formulas meet infants' nutritional needs, and any alternative should be guided by an appropriate clinical rationale. Although commercially available infant formulas are regulated and nutritionally complete, improper preparation is a recognized source of adverse events. Following manufacturer instructions carefully is essential. Correct dilution is particularly important. For example, overdilution can cause low sodium or hyponatremia, while overconcentration can lead to high sodium or hypernatremia. Powdered formulas are not sterile. Ready-to-feed liquid formulas are sterile and are preferred for infants under 2 months, premature infants, or those who are immunocompromised. Safe handling is equally important. Wash hands before preparation, use safe water and clean bottles, and store prepared formula appropriately. At room temperature, formula should be used within 2 hours. If refrigerated immediately, within 24 hours. Once feeding begins, any remaining formula should be discarded within 1 hour. Most adverse outcomes relate to preparation errors rather than the formula itself. Educating caregivers on safe preparation is a critical component in pediatric standard of care and supports safe nutrition for infants. It is important to note that homemade formulas, improvised substitutes such as evaporated milk, or imported formulas that have not been evaluated by the FDA are not recommended. These products may lack essential nutrients, may not be safety tested, and fall outside accepted medical standards. Using such alternatives can pose significant nutritional and safety risks. For both clinicians and families, the safest approach is to use only FDA-regulated, commercially available infant formulas. Some infants have special needs that may require specialized formulas and individualized feeding plans. This can include preterm or low birth weight infants, infants with metabolic or gastrointestinal disorders, and those with severe allergies. Feeding decisions for these infants should be made in consultation with a pediatrician and the broader medical care team to ensure safety, nutritional adequacy, and optimal growth. So in summary, commercially available infant formula is recognized as an acceptable, nutritionally complete alternative when breastfeeding is not possible or not exclusive. Infant formula is federally regulated for nutritional adequacy and safety. Standard iron-fortified formulas support physiologic growth in healthy-term infants. Safe preparation and correct dilution are essential components of care, whereas homemade or unregulated substitutes fall outside accepted standards. And counseling should be evidence-based, non-judgmental, and individualized. And these are my references. Thank you for allowing me the opportunity to discuss this important topic, and please let me know if you have any questions. Thank you.
Well, good afternoon. At least good afternoon to those of you in the Eastern time zones, and good morning to those of you in the West. This is your host again, Dr. Edward Halperin. If you have questions for our panelists, please feel free to type them into the question and answer box on the bottom of your screen. But we've had many questions come in from our audience during the presentations. And let's get started with some questions for Dr. Amin, please, if she could turn on her camera and turn her microphone on. Dr. Amin, you seem to have frightened at least one of our viewers who wants to know if it's okay to rinse their eyes with tap water if you're not wearing contacts. For example, if you get some shampoo in your eyes while you're taking a shower, now they're worried about getting any water into their eyes after your slides of those awful looking infections.
So, of course, people are going to get water in their eyes, and the risk is small. I would suggest that it should not be common practice to wash your eyes. I have some patients who've told me that they wash their eyes, which I don't like. If you feel like something got in there and something's bothering you, you can buy preservative-free saline. There's prepared solutions to rinse your eyes. If the greater risk happens if you actually have a scratch on your eye and then you get water in your eye, because then you allow access of the acanthamoeba or bacteria inside. So a small amount of water carries a very, very low risk. The contact lens absorbs the water, which is why the risk is so much higher, and it holds that organism against your eye for a long period of time, and that's the difference. If you don't have a lens in, it comes in and your body's natural forces to fight infection can take place.
My father was a retail pharmacist with a Halperin's pharmacy on Main Street and used to sell boric acid products for eye rinse. Whatever became of those products? Has that all gone by the wayside?
I would have to tell you, we keep eye wash in the office. It may have boric acid in it. I'd have to check the label. If basically those solutions are sterile and they're pH balanced to be safe for your eye surface. Keep in mind, if it's been sitting around on a shelf for a while, it's no longer good to use.
I learned an important lesson when I was a little boy. My father used to put labels for use in the eye only, and he would put labels on the talcum powder for external use only. And I remember as a child asking, why did he do that? And he basically said no one ever lost a nickel by underestimating the intelligence of the public, that people saw white powder and decided it was no difference between talcum powder and boric acid and would mix them up, and you had to have explicit labels. Be sure people didn't do that. Let's go with another question for you. A questioner wants to know, based on your rather frightening slides, are there extra risks for diabetics with contact lenses for these god-awful looking infections?
Yes, diabetics do carry increased risk for the simple reason that diabetics have reduced corneal sensation. They don't feel as much pain as someone who doesn't have diabetes would feel. And so the diagnosis happens later in time. So the infection could sit there unknown to the patient or undiagnosed by unknown to the patient because they won't feel that pain. Pain is your first signal to go to the doctor when there's a problem, and diabetics have less pain.
All right. Well, thank you. We'll give you a rest for a while. We have a list of questions here for Dr. Rosenstein. If she could turn her camera on and her microphone on, please. We have a questioner who wants to know whether the world is going to change for lung cancer screening with artificial intelligence. They want to know if you would speculate if you had done those studies on routine PA and lateral chest X-rays with AI helping, or if you did studies with AI reviewing the CT screening, what do you think would be different about the results for lung cancer screening with artificial intelligence augmented reading?
So from the studies that have been done already, there is some questionable evidence that if you perform chest radiographs with subtraction and get the ribs off the field of view, AI could conceivably pick those nodules up a little better. But as you recall, you still need a large randomized control trial with lots and lots of people separated into two groups. So evidence is weak, possibly, but not so much. Now that the dose is so low of lung cancer screening CTs, I get to fly somewhere in the United States literally every 2 weeks. And every time you fly, you get a radiation dose. So my radiation dose over constant flying is probably coming up to what a patient would get with an annual CT screen. So, the dose is becoming not quite of concern. And so we're not, really running back to do chest x-rays anymore. The question is, would AI get us, better results at CT screening? Possibly. What it's going to do is going to lower costs. It's going to make me way more efficient. It's just easier to read. It's much quicker. So as far as lowering costs, yeah, it's really big. Yes.
Okay. We have a listener who is raising the spectrum of potential increased death rates from lung cancer screening. I think what our questioner is getting at is the story of prostate-specific antigen for prostate screening. If you keep ordering PSAs on elderly people, eventually someone's going to get hurt by doing the biopsy or by doing an operation. Our questioner wants to know, is there a risk that someone's going to die from removing a nodule seen on CT, which turns out to be benign and would have been best off never being found and never being operated on?
So we actually have this answer in this big randomized controlled trial in LST, which I mentioned was performed in the United States, starting in 2004, ended in 2010. And boy, do we have all sorts of really, really good data. Okay, so what we know is that overall mortality reduction is 7%. That is enormous. So we have 20% mortality reduction in patients with lung cancer, right? But overall, mortality reduction is down 7%, which tells you that the benefit overall is huge. Now, to one specific person, one in the blue moon, yes, it is possible, although large studies out of Henschke studies, out of, I believe it was Cornell and Mount Sinai, LCAP studies showed that for practical purposes, no lives were lost from biopsies and taking out these nodules, some of them turning out to be benign. So in their specific population of over, I think, many thousands of people, no lives are lost. But we certainly cannot guarantee any one person that they will not be harmed by surgery, right? But neither can we guarantee we're not going to get hit by a bus crossing the street, or that we're going to, for example, not have severe myocarditis getting a flu shot or something like that. So the answer is overall, it's incredibly useful.
Well, thank you. We're going to give you a rest and we're going to have a few questions for Dr. Caswick next, please. Dr. Caswick, if you could turn your microphone on and your camera on, please. Well, we have a somewhat challenging question here from the audience. Do the baby formula companies still hand out, quote, free formula in hospitals and to you pediatricians? And what do you think of that marketing practice for formulas? We have a skeptic in the audience, it looks like.
That's a great question. So I'd say overall, many hospitals are transitioning to the Baby-Friendly Hospital Initiative. And that's a global program that was launched by the WHO and UNICEF. And this really is, this initiative is placed in part to promote, protect, and support breastfeeding and mother-baby bonding and to ensure optimal care. And in doing so, there are a lot of different steps and policies associated with this initiative and this designation. And one of them is that hospitals are not allowed to actually hand out formula samples to patients. So we're kind of seeing this transition over for many different hospitals since this is considered optimal care for patients. Thank you for the question.
Yeah. Thank you, Dr. Caswick. We have another question for you. You had a slide about the safety of powdered baby formula, mixing it up at home versus the liquid. Obviously, there's a price differential. for powdered versus prepared. The questioner wants to know whatever happened to boiling the bottles. Now, I mean, I'm old enough. My mother had a laboratory in the kitchen. The bottles got steamed and boiled, and there was a whole thing about that. But you don't see that anymore. Based on some of the concerns you raised, should we be going back to something like that?
So sterility and proper handling and cleaning, whether it's of bottles and the nipples associated with the bottles, is of the utmost importance. So kind of as I mentioned in the presentation, powdered formula is not sterile. However, if used, it does require proper hot water, so at least 70 degrees Celsius or 158 degrees Fahrenheit for preparation to reduce the risk of infection or bacterial contamination, in particular with Coronabacter. So it carries a higher risk of preparation errors, such as wrong ratios, which can lead to improper nutrition. And the reason why we typically recommend the liquid formula for immunocompromised patients or premature infants, since they're considered immunocompromised as well as their immune systems are immature, is liquid formula sterile. So it carries a lower risk of contamination and it requires minimal handling, so it's easier to use. But powdered formula, you just have to be more cognizant, both with liquid and powdered, but especially with powdered, more cognizant of proper preparation of the feeding. Thank you for the question.
Thank you. We'll let you take a rest. We've got a questionnaire who wants to put Dr. Wolf on the spot. Well, Dr. Wolf, the questioner says you're in favor of helmets. That's pretty clear. Why don't you say you're against tackle football for children or heading the ball in soccer if you're this worried about prevention?
Well, I agree. Football is concerning, but football with people well trained on making sure that the kids don't spear each other, which is where they use their head as sort of a weapon. Good training and teaching them really prevents a lot of the injuries that you've seen in these professional football players. So most amateur football players do not get head injuries, but some certainly do. So it's really about good training. So I do recommend football with caution, and even soccer with caution, teaching children how to do it properly and correctly. But I don't want to stop children from having fun. There are plenty of people who play sports and have developed perfectly fine and charming. So that's really important. Thanks for asking that
Yeah.
question.
Now we got another one here, a somewhat challenging question. Questioner writes, I'm worried about the decline in physical examinations and the tendency of people to let's just order a CT. Isn't the CT scan quickly becoming the new complete blood count in emergency rooms? Are we overutilizing CTs? Is this all part of defensive medicine?
I think that's a great question. And we really are teaching people to be more thoughtful and focus on the physical examination. Because not everybody needs a CAT scan. We really don't want to radiate people with radiation. You just heard that from Dr. Rosenstein. The least, the better, because there's so many other exposures that we have. But if someone has a perfectly normal examination, and the headache is resolving, we will hold on the CAT scan. We really recommend that. It shouldn't be just done, but if it's a new headache or suddenly worsening headache, then it should be evaluated. If the trauma has a loss of consciousness associated with it that was prolonged or atypical, it should get some imaging done. So these are the really good questions to ask the providers in the ER is this indicated? Is it justified? How is the patient doing? And in children, most of the time, you don't have to do anything. The exam tells you the story.
Mm.
Thanks for asking that good question.
Thank you. We'll let you have a rest. We've got some questions for Ms. Friedman. She could turn on her camera or microphone. Um, you talked about how long the specimens should be held. The questioner wants to know about privacy concerns. If I get one of these screening panels, am I going to compromise my chance of getting a job or getting insurance because of acquiring this information?
It's a great question, and a question that most of our patients have, especially when they're considering cancer genetic testing. So, there was a law passed in the early 2000s called the Genetic Information Non-Discrimination Act. And what that law does is it protects people who are doing genetic testing from insurance and employment discrimination. Now, it only applies to certain insurances, such as life insurance and long-term care and disability insurance are not included, but health insurance is included. So, for example, if somebody tests positive for a mutation in a gene that causes a high risk of cancer, then that person cannot be discriminated against for their health insurance. So, health insurance cannot raise their rates or deny coverage because they're going to need their health insurance to cover the screening and management for the high risk of cancer. But life insurance companies and employment can discriminate against a patient. I'm sorry, employment cannot discriminate against a patient. A patient cannot be fired for their genetic testing results, but life insurance can discriminate against a patient unless it is an existing policy. So existing policies are not affected, but new policies, when somebody applies for them, they can ask for genetic testing results and either raise rates or deny coverage.
Mm. Good information, important. Thank you. Another questioner wants you to talk about what's the chance you're going to find information in breast cancer genetic panels that'll be of most importance to your daughters or your granddaughters? Some thoughts about transgenerational obligations from testing, please.
Yeah, of course. So with genetic testing, we always take a full family history and we ask if a patient has children or grandchildren. And I would emphasize that this isn't just for daughters and granddaughters, but for sons and grandsons too. We know that certain certain cancers due to genetic causes can cause male breast cancer, as well as prostate cancer and pancreatic cancer, all things that can affect boys as well. So when we take that family history, we tell a patient to make sure they notify their family members that they're doing genetic testing. And if their testing is positive, meaning that patient's at high risk for a hereditary cancer syndrome and at high risk for cancers associated with it, then they should be informing their children and grandchildren. And as genetic counselors, we usually supply a letter of an explanation so that a patient can give that to their children, grandchildren, and any other family members. Thank you so much for that question.
Thank you. We're going to let you have another break. We've got another question that's come in for Dr. Amin, please. Dr. Amin, one member of the audience has written in, should immunocompromised patients and diabetics use contact lenses at all? Are they contraindicated?
I think if the patient is responsible and follows the guidelines of keeping the hands clean and keeping the case clean or using the daily disposables, I think that's fine. You need an eye exam before you get contact lenses. So in general, it should be fine. However, if you have dry eye or other problems with ocular surface, then contact lenses are not easy to wear and you'll be uncomfortable, and then you might be increasing your risk. So dry eye and ocular surface diseases would prohibit easy or good contact lens wear. So if there's other medical problems associated with those conditions, the eye exam is important ahead of time with an ophthalmologist. Thank you for that question.
We have someone in the audience who wants to know what the price differential is for these disposable contact lenses versus the others, because it sounds like you're very much in favor of them, but there must be a downside. I'm going to bet it's the price. Yeah,
so contact lenses are they're made by different companies and come at different costs. They have different moisture content. I don't sell the contacts, but different lenses have different features. However, the daily disposables can be about $1 a day per lens, which is kind of how I put it. And I do think for younger people who are not careful or the ones who are not going to follow the rules, like teenagers or college kids, I absolutely want them in daily disposables because they're the ones who are going to sleep in them and not be careful or try to reuse them. I would think people in their adulthood would be more careful and they could use the weekly or the monthly so long as they follow the guidelines, but cost is a consideration. people have astigmatism, and those are other types of lenses. So the cost varies depending on what type of lens. And so it's very individual. Thank you for that question.
Well, we're answering that one, someone has written in, do the lenses put in during cataract surgery run a similar infection risk?
No, absolutely not. The lenses from cataract surgery are inside the eye. And so at the time of surgery, we take out the cataract and we put an intraocular lens. It's called an intraocular lens. It goes inside the eye, behind the iris, and then it's sealed. So that does not carry this acanthamoeba risk, because acanthamoeba comes from the outside or externally, and it's on the surface of the eye. The cornea is like the clear watch cover. It's clear and on the outside. And the lens that we're talking about for cataract surgery is on the inside of the eye.
Thank you. Well, we'll give you a break again. Dr. Wolf, please. Dr. Wolf, we have a listener who is concerned about it's not the good old days when you could call the doctor because the doctor had an office on Main Street in a repurposed house. When I try to call the doctor, I get a recording. It says touch 1 for this, touch 2 for that, touch 3 for this, touch 4 for that. I'm lucky if I ever get a human being. And if I even get a human being, it's a human voice that says leave a message. Now, if my child's bumped their head and that's what I do, how long am I supposed to wait for a call back before I give up and pack them up and take them to the ER?
That's a great question. So first of all, I hope our talk gave you some ideas of things that can make you feel more comfortable and not have to call your medical provider. But all the medical providers are really supposed to have a really good on-call system. You know, we just went on our own system where you leave a message, but it gets sent right to us, and we really try to call people back as quickly as we can in that process. There are also urgent care centers that are available if you're sort of not 100% sure that you need to go sit in an emergency room. And urgent care centers are also really useful in evaluating for a bumped head. And of course, if you think it's really serious with significant loss of consciousness or any of those warning signs that I gave you, the bruising behind the ear, the rings under the eyes, those I think you should go to the emergency room. Thanks for that good question.
Thank you, Dr. Wolf. We're going to let you have a rest and go back to Dr. Caswick. We have a also kind of welcome to the modern world question for you, Dr. Caswick, if you could turn on your camera and your microphone on. This person wants to know basically about your slide, which says baby formula is highly regulated by the government. And the questioner is writing, well, sure, but what happens if I'm buying stuff online? And how do I know where it's coming from? And how do I know if it's part of what's being regulated? And I don't go to the store anymore and buy. Everything comes in a box left on the front porch. So now do I have to worry when I go click, click, click and order baby formula about whether it's actually under this government safety monitoring?
That's a great question, and it can be difficult to tell. Some of the things that we advise to look for, since there is no label that says FDA approved or FDA regulated on these infant formulas, but verifying that it's marketed in the US, looking for iron fortification on the label, checking for a use by date, ensuring that there's one, and all U.S. infant formulas must meet FDA nutrient specifications, and it's something called 21 CFR 107. And so you're able to look up and verify whether it's been FDA regulated, but it's not directly there in the formula. So a few of those kind of hints that we advise for people to look at. And then if there are still questions, reach out to your pediatrician or your healthcare provider, because they'll also be able to help you as well. Thank you for that great question.
I bet that there's some members of our audience like me who are old enough to remember where a large part of the practice of pediatrics was literally writing out by hand the formula for the baby. Somewhere in my scrapbook is my pediatrician. Take so much Karo corn syrup and mix it with this and mix it with that. And there was a little chemistry lab going on in the kitchen to make the baby formula for that's I don't know, are there ever anybody anymore that needs customized compounded baby formula, but the pediatrician has to write it out for them?
So oftentimes, actually, here, for instance, in the NICU, when we are sending patients home, sometimes we do have to write scripts out for patients if they require a specialized formula. Or we also write scripts to help with WIC for the cost of formula because it's not inexpensive, regardless of what kind of formula you're using. So it's not infrequent that the provider will write out a script, but we don't always have to do it. But if there's any question, ask your pediatrician and they can help you out with that as well. Thank you for that question.
You used an abbreviation some members of the audience might not know, NICU.
The neonatal intensive care unit. Yes, thank you.
Okay. Thank you, Dr. Caswick. I want to thank all the members of our panel for their presentations today and for answering questions. As often happens, the time has flown by. Thank you for joining us for webinar number 34, 90 Minutes, the medical magazine of the web, brought to you by New York Medical College and Touro University. Our thanks to Michael Cotter, Michael Frankfurter, and Ashley McCarrick for doing all of that internet magic and technology to make these broadcasts possible. Thanks to our audience for joining us, and we will see you all next time for webinar number 35. Have a good rest of the day, everyone. Bye-bye.